Back to Practice has been made possible with support from Allergan and Novartis. We'd like to thank our sponsors for their support of this programming.
Today, we're going to talk about clinical and surgical protocols, which changes are here to stay. And I am joined by two wonderful and well-known international retina specialists. We have María Ana Martinez-Castellanos from Mexico and Dr. Matteo Forlini from Italy. And we will get to them in just a second. Today's focus, once again, will be what types of things are actually going to be here permanently because of the COVID-19 crisis, what changes to our OR, clinical routine, and whatnot. As just an update here, July 24th, 2020, worldwide, we have 15.5 million cases of COVID-19 with 633,000 deaths. In the United States, we've had 4 million cases with 144,000 deaths. In Mexico, we've had 370,000 diagnosed cases and 42,000 deaths. And in Italy, which was one of the earliest and hardest hit areas, we have 245,000 cases and 35,000 deaths. So let's start out with Matteo. Matteo, Italy seems to be a location that has weathered the COVID storm, a very vicious storm early on for you all, and seems to have come out of the other side. Is that true, and how are things on the ground in Italy?
Well, yes, actually in Italy, we had one of the worst scenarios in March. Actually, in this last few months, like June, July, everything went back to normal life in Italy, pseudo normal life, but I can say that all activities reopened. So health activity, I mean public hospital, private clinics, but in all different aspects of the normal life, like restaurants, also now it's summer, so even clubs on the beach, even some concerts, quite normal life. Of course, in every scenarios, we are using new rules. So, for example, when you go in public hospital, you can find the chairs, but one chair is good, one chair is crossed, so people cannot sit all together. And that means that you don't have a crowd of patients like in the past years. And there are many small differences. For example, when you visit a patient, you cannot, you have to leave outside the parents or the wife or the husband. And in some clinics, the relatives stay outside, like in the street. They don't want the relatives go in the clinic. Because for every patient at the door, the nurse have to measure the temperature to check the fever, and they do for surgical patients before the operating room. They check the nasopharyngeal swab specimen to check if it's positive, and also the serologic specific antibodies. This is for every patient that needs operating room, even for injections, for macular degeneration. So you can understand that all these steps for every patient provoke a huge work to do. And so for every patient, we need a lot of time of preparation. And that's why now, especially in public hospital, if we have one morning in operating room, we can do only maybe 5 cataract surgeries or maybe only 2 vitrectomies. While the year before, usually you know, in operating room in one morning you can do 15 or 20 cataract surgeries, or maybe 4 or 5 vitrectomies. So I said at the beginning, it's pseudo normal life, because we are doing everything, but very, very slowly. Because for every patient, we have to do many check papers, signatures. And that means that public hospital is working with very few numbers of patients and the surgeries. On the other side, the private clinics are working more than before, because all these patients are calling other clinics, or sometimes the patients calling me directly, because I'm working both in public hospital in the morning and private clinics in the afternoon, for example. So patients call me and tell me, hey, public hospital, I have to wait 1 year for cataract surgery. And so I want to be operated soon. And so they ask me, or they ask other colleagues to go to other private clinics to operate for the phaco, for not urgent macular pathology, like macular pucker or macular hole. I want to just to point that for urgent pathologies, we are managing good. For example, retinal detachments, hemorrhages, or macular degeneration needing injections. We are keeping a good rhythm, because it's urgent surgery. So when we have a retinal detachment, we operate retinal detachment. The problem is for the not urgent patients. So the macular pucker or the cataract surgery have to wait 1 month, 2 months, 3 months, 4 months, because they are not urgent. That is the problem.
Now, Matteo, you said that this is actually increasing your private practice volume. Do you not have to do some of the same protocols in private practice, or have you just found a way to do it more efficiently?
Yes, we use the same protocols of preparation, even in private practice. But the difference is that usually in Italy, public hospital usually receive a lot of patients, really a lot of people. That's why the public hospital is in crisis, because it's difficult to manage all these people. Because on the other side, private clinics usually are smaller. So with in the smaller clinic, you have few patients, so you can manage every patient easily. Public hospital, of course, so many people to manage, so many problems altogether. That's why the weak point now is the public hospital in Italy.
Very interesting.
Yeah.
Maria, in Mexico, what is the status of COVID-19 just in general in the public, and then also specific to your practice?
So right now we are racing in the numbers. We are not even close to be flat. We're on the other side of the coin than Italy. We are just racing. The thing is that the government has opened everything, and we're having this huge amount of new cases every day. The hospitals are collapsing because of the amount of people that are getting into the hospital, particularly in ophthalmology. In public hospitals, they are not really now seeing ophthalmology patients. So now private practices are racing, but people is still afraid of going out to the street. The ones that are afraid, because many are just in the street without a mask, and well, it's complicated to put everything in order with that. But ophthalmology clinics in private hospitals are basically nullified. They are not seeing as many patients as before. Many ophthalmologists in some private hospitals, in some public hospitals, have to be into the COVID triage. In private, no, the private hospitals are completely different. Private hospitals are now racing in number, of people that we are screening. And now we have new problems. For example, in my case, that I am a pediatric retina and I see all these ROP patients, now we have to see these babies that they have COVID, the mothers that have COVID. We don't really know how was the transmission, if it's a vertical transmission. There are papers that says that there is no vertical transmissions, but there are papers that says the contrary. And soon we will have to deal with all the pregnancies that were infected in the first trimester, because we still don't know if there is a teratogenic thing with the COVID and what is going to happen next, because this is it's very early. We feel like we have been through this for years, but now it's just a couple of months. So we will have to deal eventually with the pregnant women that became sick during the first trimester and what is happening to that baby. So
wow, you don't even think about that possibility that it could cause some sort of effect on the unborn child. That is absolutely tragic. It hadn't even entered my mind. Maria, what are you seeing in ROP kids who already have pulmonary issues that are infected with COVID? Do they struggle even more? Do they present differently? How is it to manage those babies?
For example, now we're putting together all these cases, and they are really sick in the pulmonary. The pulmonary disease is really bad. And ophthalmologically, we see from eyelid edema to keratoconjunctivitis, this chemosis that is very, very, very aggressive with the eyes. And we have been performing some angiograms because we see vascular problems in the eye. And we have vasculopathies in the periphery. We have choroidal infarction, and we have non-perfusion nearby the optic nerve. And this is very new information. We still don't know what to do with these cases, but we see this in premature babies that are in the hospital. We do have some Kawasaki-like syndrome in bigger babies, in older babies and children. But we're learning with every day about new things with the virus, not just the ones that we're learning about adults, because also in adults we see a lot of pathology in the eyes.
That's so tragic, because you have these kids that are the weakest and most vulnerable, and they have these additional issues. So these findings you're seeing are very separate and distinct from what you see with ROP?
Yes, they're completely different. And now there will be they will have premature, so they will develop some degree of retinopathy of prematurity, and we add something else. So it's complicated. There are not many. We have in a very big hospital, like 15 babies, but the numbers are not that high. But anyway, they are babies with this disease.
And you said that the public hospitals, what kind of testing is being done in Mexico now for, in general, good access to testing, and then also specific to your clinic and your patients that you see?
Actually, in the public hospitals, testing is not really happening. And that's an issue. And actually, the World Health Organization just called Mexico to do more tests. For example, in my private practice, we perform the rapid test for emergencies, for urgent surgeries, and we ask the patient that is going to undergo a surgery to have the PCR, right? But in public health, they are not testing everyone, and there is an extraordinary raise number in, for example, atypical pneumonias. They don't categorize it like a COVID. They just say it is an atypical pneumonia. So we don't really know the numbers. Numbers be much higher than what is in the news.
Matteo, you've seen this, you've kind of moved through this, and I feel like the US may be straddling the line. It does more testing like Italy did, it's starting to lock down more, but it still has much of the same mentality that Maria is describing in Mexico of we want to keep our economy open. What was the key to success in Italy? I know you got hit really, really hard, but what would you advise people like us in the United States that it's rapidly out of control, and in Mexico where it seems to be out of control as well?
Well, actually, Italy really had in the beginning, in March, a huge lockdown, very strict. And of course, the problem now is the economic crisis. So, I mean, the key of success, meaning the solution of the medical emergency, provoked problems in the economics. So, you know, it's the two sides of the same coin. Actually, Italy politics was very strict, was very exaggerated lockdown. So everything was closed for 2 months almost. So of course, many workers, many families had problems, because you can imagine in Italy, a lot of people work in the touristic field, in the restaurants. In summer, in Italy, summer is the moment for the tourism. So a lot of people, I mean, as a doctor, we are medical doctors, so we always have patients to visit, to care. But people that works in the tourism, or maybe they have hotels, restaurants, had a lot of problems. But this lockdown so strict actually worked, because now in Italy, every week on the news, we are hearing less cases. So nowadays, we have really very few cases. Everybody here have the fear that in the autumn, in winter or autumn, maybe we don't know, but maybe coronavirus could rise again because of the climate, you know, because autumn can be cold, and so everybody are not so happy, because maybe coronavirus is just sleeping. We don't know. But if coronavirus will not rise again in autumn, situation in Italy now is good. It's more the fear than the reality, because we have
the economy is working again in Italy.
Yeah, well, everything started now. Okay, now everything is working, but we had this huge hole, because for 2 months, 3 months, there was a stop. So many industries, many companies, many factories, of course, they had zero incomes. Some people were fired. Some people lost the job, because, you know, where there are no money, it's a circle. Okay, now politics, our Prime Minister Conte, okay, now in Italy, you know, in the European Union, we have a special equilibrium among all the European states. So Italy could receive money from Europe, but again, there is a side effect, because Europe gives us money, but that means that our debt is more, because the money that we receive, one day we will have to return the money. So it's difficult to understand if how many problems we will have in the future. Now it's not so bad. Actually, now it's good. But I'm not economist. It's not my field. But when I hear the news, or I can hear some people, expert in economics, they say that this period it will be a problem because we have a debt. And so I can conclude that we managed good the medical emergency. So the first goal is achieved. Now there are many consequences of that. I know that other countries, maybe they did lockdown not so rigid, so many activities are working, so economics are better, but maybe now they have more problems for people dying or sick. It's difficult to choose.
Maria, I'll tell you, in the United States, it is a very political issue, the difference between health versus the economy, and it's very polarizing. Is it polarizing in Mexico? What is the rationale behind keeping things open, not doing testing and other things like that, given to you from the government?
Actually, they say that when the US has a flu, Mexico has a pneumonia. And it's true. And it's true. Because we're neighbors and we share a lot of things, and politicals is one of them. Our president doesn't even wear a mask. He as well as your president, he's like against the mask wearing, and he says that if they test a lot, we will have a raise of numbers. Of course, we will have a raise of numbers, but then you can track the contagious areas, no? But the political issue is big, and it's really polarized. There is no grace, it's black or white. There is no grace, it's or you are with me or you are not with me. So it's complicated to deal with something like that. There's this Secretary of State that came out to say that she's drinking these drops that are like vitamin C, and that's why she has never been contagious. So she's healthy because of that. And it's like this magical thing that is also in the people. And of course, the poorly educated people that they are drinking chlorine, or it's the same as in the US. But it's what I said at the beginning. If you have a flu, we have a pneumonia. We are just next to you. We're neighbors. We have the same issues, sometimes a little bit different, but the same. The testing, the math, and everything.
I can say from the U.S. perspective, it's very frustrating to see the medical experts being doubted by the administration when you know what's right and people believe these false narratives. And finally, we're starting to get our leadership on board with at least wearing masks, which is irrefutable. We had people questioning here in the United States, oh, masks, it's a way to control us, or it's they are dangerous. They can lead to, elevated levels of carbon dioxide in the system, and just all of these false narratives that were just not true. And it's very, very harmful. Let's talk a little bit about your clinic, Maria. How is your outpatient clinic functioning? What are you doing differently now than you were before COVID-19?
In the private, we are now scheduling patients with more time. Before we had patients every 15 minutes. Now we have every 30 minutes. So we don't have too many people in the waiting room. We have this device that puts some liquids when you get into the clinic. That's because we don't think that this is going to make a difference, but the healthcare from the government, from my state, is requesting it. And for surgeries, we have to have test of the patient, the test of PCR. And if it's an emergency, I told you, it's just the rapid one. And us as healthcare, we have the test, the finger test, every week. And every 3 weeks, we have the PCR also performed, because it's socially taking care of your patient. We could be asymptomatic. So ophthalmology is one of the specialties that is considering high risk, because we're less up 2 meters from the patient, more than 2 minutes. Is the 2 and 2 rule? Less than 2 meters, more than 2 minutes. So if we're doing a vitrectomy that takes us 40 minutes or more, you're in risk of being in inhalating the virus. So we have to perform this test, and it's for just taking care of everyone around in the clinic, in the private clinic. In the public clinic is different because we depend on what the government says about the testing. So I am not working now in the public except 1 day a week. And of course we wear all this gear and everything. And in the public clinic that I test premature babies, that is 3 hospitals in my area, what I did is I hired an optometrist that is really skilled taking pictures with a portable device. And he has all the gear to wear, and we're doing telemedicine. He's going into the clinic, and I am reading the photographs from my phone actually. And the babies that need treatment were going to the hospital in a special area, or they move the baby to my private clinic so the baby can have the treatment. Also, we have another optometrist that goes to take pictures of diabetics or anything from retina to the house of the patient. And because it's easier, if they have something, we make them come to the clinic, but if not, they just stay home, especially the very elderly. And we also have one that is doing the glasses and refraction, easy things in the house of the patient. We're doing a lot of telemedicine now.
That's really amazing. So your telemedicine is more sending people to the patients, to their homes to do the imaging or to do the evaluation. And then do you consult virtually with them through Zoom, or how do you communicate then with the patient?
Usually by phone. By phone. Some of them are very elderly, and they are not really familiarized with the technology like that, but by phone is easy. And usually we contact them by phone. It's easier with the babies. The parents are young, and their generation just grew up with the phone, so with them it's easier. But with elderlies, it's not. We just consult by phone.
And Maria, are you doing injections in patients' homes? How are you handling your injection patients?
The injections are in the clinic. They have to come to the private clinic, and we schedule a day just for injections. Our injections are done, as it's a faster procedure. We are not testing before the injection for COVID. But what I do, we have these acrylic boxes similar to the ones of the anesthesiologist, and we put the box over the head of the patient. So we do the injection, and then they leave. But we use this box, that translucent box, and we have 3 or 4 boxes, and we clean it every patient.
And you said that you're spreading out your appointment times from 15 minutes to every 30 minutes. Are you working longer hours? Are you working Saturdays? I know you have some allied health professionals helping you, but what does that look like? How's that impacting your schedule?
Well, the number of patients is lower, of course, but we're compensating with the one that is going home to the home of the patient. So we still have a good number of patients that have been screened in home, and they do not require a treatment. It's just we see what they have, and if the diabetic retinopathy, that is what is more frequent in my area, is fine, or they have to come for injection or surgery or laser.
And do you find you're doing more laser, Maria, for the diabetic patients for fear that this is going to go on and we may not be able to get those patients back in?
The problem in Mexico, and maybe you have seen these videos that we present in the meetings that are really complicated diabetics, is because they don't have a really good preventive medicine for many diseases, and the retinopathy is one of them. We see them when they are in advanced stages. We don't see them in very mild stages. So we're still working with that. We don't do more laser because they are already coming to us when the vision lowers or things like that. And for programmed surgeries like cataract surgery, we test everyone. For urgencies, we have to do the fast test, but for everything else, we program that with time. It's been difficult. It's a lot of work. It's a lot of work. But I think that we have to just adapt to it, because it's what we're going to have to do for the next probably 2 years, maybe, hopefully, hopefully. But we have to adapt to the new reality.
And you mentioned this earlier, but I just want to come back around to it. There are some ophthalmologists and retina specialists who are being asked to work in the ICU. Is that correct?
Yeah, it's correct. There are some.
And those are the public hospital employees, I would assume. And how are they handling that? What are you hearing back from them as they?
Well, they are more in the administrative area and not exactly screening the patients, but they are not doing anything related to ophthalmology. They are doing something else because we were lack of doctors. Many quitted. A lot of doctors and nurses and personnel from the hospital, even the guards in the doors, many people quit because they are not having all this equipment and all that. The government is not providing it in some public hospitals, so they prefer to quit, to be jobless than to be sick.
So you have physicians in the hospital that are quitting because they just, wow, that is
for example, in the babies, that is where we measure a lot of things, because we have this program with the telemedicine and everything that we can see the evolution of things. Now I'm having a horrible raising number of oxygen-induced retinopathies, more than ROPs, like a clean ROP. And the thing is that many nurses quitted from the NICU. So they have now nurses that are not really trained to be in a NICU, and they just put the oxygen high to the babies because they just want to make sure that they are having something alive the next day. And so now we have this collateral damage of babies that are not taken care as they should be, because the nurse is not trained as they should be, because the trained nurse quit or died or got sick or is in quarantine. So that's also something that is going to happen, and I think it's going to happen everywhere. And maybe Matteo had something like that in Italy, that we have sicker patients because of the lack of personnel to take care of their disease, not only in the eye, but in other areas of the body, the patients with cancer or the patients with other chronic diseases, that they could not have a good attention during the lockdown, the real lockdown, for example, in Italy.
Exactly. I confirm. We had the same problems. I remember some patients, for example, I remember patients, I was preparing for a surgery for example, macula hole or macula pucker, and they were scheduled for March. But then in March, there was COVID emergency, operating rooms were closed, so the surgery was canceled. Then I saw the same patients in May, just preparing everything for the surgery, but I found out that the same patients, after 2 months, for example, patient was diabetic, or that patient had the problems cardiovascular, and they had more problems of general health for, blood pressure or anticoagulating drugs. So I couldn't operate because the patient was not healthy anymore. So this patient had to go to cardiology, had to go to many other problems of general health. So like Mariana said, this period of lockdown was very hard, especially for these patients, more than ocular pathologies. Another observation, actually, I don't know how did you manage this in the US or in Mexico, but in Italy, especially in March, when it was a complete lockdown, people that had macular degeneration, and people usually doing monthly injections, didn't do injections in March and April. So when they came back to the clinic after 2 months of nothing, some of them, they had a worsening of the macular degeneration. I mean, not every patient, but some patient really paid because we found some big macular hemorrhage or some big exudation. So that was a problem. Now, of course, we are back to do injections, but some patients had the problem of the lack of injections for a couple of months.
You know, we never really had a true full lockdown, Matteo. So for our practice, we never really stopped working. We were one of the practices, ophthalmology, general ophthalmology, cataract surgery, and elective procedures were required to shut down for 3 or 4 weeks in the United States. But for retina, because we were considered an emergency service, we continued to work, although we saw a reduced volume of patients. Most of what we saw that were problematic were patients who couldn't get into their eye doctor to be diagnosed in the first place. Our normal patients who kind of knew the risks would get in and would get treated. We saw very few that had existing patients that had problems. It was more the patients who had lost vision and didn't know where to go, you know, because they would have normally seen their eye doctor, but the eye doctor was closed, so they just waited. And frankly, for our economy, we probably shut down not hard enough and maybe a little bit too early, because the rest of the United States reacted to what we saw in New York and New Jersey, shutting down everything. And that has made it very hard to get people to buy into shutting things down now. Maria, have you seen patients that don't come in a timely fashion because of COVID, or are patients getting in to see you pretty routinely?
Yes, we have some issues with that. In public hospitals, they locked down some of this. Ophthalmology was probably one of the first ones to lock. And we are now seeing a lot of complicated patients that they didn't have a treatment timely. Yes, because of that.
Matteo, back to you. So you've kind of come through this, still a threat. What are the things that you implemented during COVID-19 when it was bad that you're continuing to do now and that you'll continue to do going forward? Things like telemedicine. Are you doing fewer office visits and more injections? Are there things that you've learned through this that make you more efficient?
Well, telemedicine, yes, because actually I remember that last year also, I mean, that was a topic that we were already discussed many times during congresses, for example. So I think telemedicine in COVID period, telemedicine had the final push. Like telemedicine was already a reality, but now it's even more a reality. And so I think for telemedicine is now probably more and more in the future. Not only because of COVID, but COVID was a period, was a situation that enhanced telemedicine utility. So I think that this is a good point. Another observation, for example, about webinars, like now, for example, because we already had the tools last year for doing this kind of conversation. But actually last year, nobody was thinking about these webinars. Now we are forced to do it. And actually, this is a new way of doing conferences or just a conversation like now. And so this is a new way that probably can continue, I believe, because it's very easy. we are talking among Italy, US, Mexico, like friends, like at the table. So this is nice, for example.
It is. It's amazing the barriers that are broken down when you take away travel. And I'd just like to point out that right now the ASRS meeting is going on and everyone internationally has access to that now, unlike previously where you'd have to wait to see the presentations online. And I believe your Retina is going to be the same way. So it definitely breaks down those barriers to international education and sharing ideas. Back to telemedicine, Matteo, are you bringing patients into the clinic to have imaging and then calling them at home? Are you sending people out like Mariana was doing, where you send someone to their house and then they send pictures back to you? How do you execute telemedicine?
Well, actually, in our experience, it's more from, okay, we have small offices in the territories, and usually we have a big hospital in the city. So now, since the problem is to receive all the patients in the big hospital. So now the solution is patients go, as I said before, patients go to many private clinics, small offices, many ophthalmologists all around. And the ophthalmologist, for example, can do OCT, and maybe he's not an expert in retina, he's not a retina specialist. So the ophthalmologist can send us to our service the picture or just the WhatsApp, I don't know. So this is a communication between our retina service and many ophthalmologists, or sometimes even general doctors, like just communicating with WhatsApp. So this is to avoid the migration of people. So the patients don't come to us, but I can see the pathology, I can talk with the doctor, and I can say, okay, this patient needs injection, or this patient don't need injection. So just oral therapy, for example.
That's a very interesting and distinct hybrid from what Mariana was doing with sending the people to the home. And in the US, we don't go into the homes, but we tend to bring people, in my experience, into our offices when we're not using them and do the imaging and then call them back. But I like your idea, Matteo, of discussing it directly with the referring doctor. Then the referring doctor can actually message the patient. So you don't have to, it doesn't occupy more of your time from that standpoint. Are your referring doctors then the ophthalmologist doing the injections, or are they sending the patients to you for the injections?
They send patients for the injections. So the referring doctors usually just make diagnosis, or the referring doctors ask me about diagnosis, and I can say, okay, this patient don't need injection, see next month. Or this patient needs injections, so the patient will come to us, but just for the injection. So yeah, injection in the hospital, in the big center of retina, yes.
Let's talk just a little bit about clinical training. Mariana, how has this impacted the clinical training in Mexico of residents and fellows?
Well, even one fellow quit because she was not learning about what she came to learn. But it's interesting that it's a year that some may consider it like a lost year because they are not learning what they were supposed to be learning. And some will consider it like an opportunity to learn a different way to do things. Example, telemedicine, because some of them are more into this tele-academics, telemedicine, tele-learning. And it's in a very interesting time because we from one day to another, we had to change the way we were doing things. Now in the clinics that, for example, I am only teaching how to do surgery to the fellows 1 day a week. So they try to put all the surgeries together in just 1 day. So I can teach them how to do the surgery in little babies. But for for them it's a challenging time. For the people that is in training, it's a challenging time. Also for the ones that want to come for the next year. I don't know how you're going to manage it, but we still don't know what to do with the ones that want to be trained for the next year. We don't know if we have to keep the ones that are now for another period of time so we can pay them their time when we were locked in partially, or if we're going just bad luck and go home and we have a new trainee. So that's an impact in education also, because, for example, for an infectologist, this is like their dream come true. But for somebody in a different kind of medicine area, it's a horrible nightmare that they are not learning what they were supposed to be learning, because there's no, everything changed the way of how we're doing it. I don't know if Matteo has students in his private, but I think that this is something worldwide, so that we don't really know what to do with the ones that are coming next year.
Matteo, yeah, give some feedback. How is training now in Italy? Since the main bulk of the virus has improved, is training resumed like normal, or is it different than it was before?
Well, no, actually the training now is back to normal training, because in our public hospital we have some young residents or fellows, and actually they just did what we did. I mean, in March, April was everything lockdown, but in May we went back to work, and residents too, and fellows too. So the training is still working as usual, so there is not an issue. As I said before, the problem in the public hospital now is that everybody do less surgery. So less surgery for us and less surgery for residents. So the training now is slower than before. But I believe it's just a period, because in Italy, every month is better. So maybe if we have this conversation I hope, maybe in November, maybe it will be better. But nobody can know if the coronavirus will come again more dangerous again. I don't know. It's just a projection. Actually, I think that, of course, the pandemic is a tragedy, but I believe that, as John said before, really now the world is speaking the same language, because in every part of the world we have the same problems. Now we are seeing that US, Mexico, Italy, and many other countries, we are dealing with the same problems. So maybe it's the first time that all the world are facing the same issues. So maybe this is a historical period, very particular in this way.
You know, Matteo, you give me great hope to see someone who's come through this in a country that's come through this, and that things can start to look normal, and that it can, with doing the right things, we can get this under control. Mariana, I'm afraid we are in the same boat. Unfortunately, we are in trouble. I really, truly believe at this point. And I really hope that you all stay very safe. I look forward to seeing you both at meetings. Unfortunately, it won't be in 2020, but I really hope that we can have in-person meetings in 2021. But regardless, I appreciate you coming on. Let us know if you need anything, and I look forward to talking to you again in the future. Thank you so much, and stay safe.
Back to Practice has been made possible with support from Allergan and Novartis. We'd like to thank our sponsors for their support of this programming. This webcast podcast is intended solely for ophthalmic healthcare professionals and ophthalmic industry representatives. By accessing this webcast podcast, I acknowledge that Bryn Mawr Communications LLC, herein BMC, along with any all third-party corporate supporters of this webcast podcast, makes no warranty, guarantee, or representation as to the accuracy or sufficiency of the information presented in this webcast podcast. BMC, along with any all third-party corporate supporters of this webcast podcast, do not endorse, approve, recommend, or certify any of the opinions or information presented or mentioned. BMC expressly disclaims any and all liability or responsibility for any direct, indirect, incidental, special, consequential, or other damages arising out of any individual's use of, reference to, reliance on in this webcast podcast.